So liver stuff. So liver can fail, right? So it's going to fail acutely. That's called acute liver failure. And it's going to fail chronically, right? So acute liver failure can lead to chronic. There's certain reasons, like hepatitis B, hepatitis C, can lead to cirrhosis and lead to end-stage liver disease. There's different stages, right? You can have acute on chronic liver failure, just like you have acute on chronic heart failure. Similar situation. But once you get to cirrhosis, there's a lot of complications involved with it, which we'll talk about, right? There's a lot of problems that can occur with liver failure, right? Same thing with acute liver failure, but definitely with the chronic liver failure, you're going to start to see all these different things are going to start showing their ugly head, right? So these are all the complications that might develop from someone with cirrhosis, right? There's a lot of things that can occur. And from cirrhosis, you could develop liver cancer. So if they don't get liver cancer, hopefully we get a liver transplant in the meantime. That is our ultimate fix once someone gets cirrhosis. But also acute liver failure might need a liver transplant. You can have acute decompensated liver failure or fulminant liver failure, where it's like a rapid decline in liver function and they need to get transplanted immediately. Okay, so you can have damage to your liver of some sort that can cause, again, it could be like a Tylenol overdose, it could be a ETOH binge. All these things can lead to acute damage, but eventually, like chronic ETOH use or chronic poor diet with non-alcoholic steatohepatitis, NASH, right? There's another, I think it's on here, you got NASH as well. Can also cause damage to the liver over time, causing fibrosis, and that eventually leads to cirrhosis, right? And you start losing function of that, and then you start getting a fibrotic liver that will then ultimately require liver transplant, but you have all these other complications in the meantime. Okay, so cirrhotic liver is very, very scarred. That's what cirrhosis means. And we're going to have a lot of problems with the portal circulation that comes out of it, right? It's going to start having an increased portal BP, right? So increased pressure. Let's see, P for now. All right, so that's the idea behind liver stuff. So what are the top 5 liver functions? How many functions does the liver have? Has more than 500 functions, right? So your kidney has 5 functions. Kidney can do erythropoietin. It can, it can filter blood and reabsorb stuff. I mean, you can really stretch up to 8 if you say like reabsorption and secretion, etc. But it can do, EPO. It can do vitamin D activation, and it can do the RAS system. So I mean, that's like one hand. That's what the kidney can do. The heart can pump blood. It can release AMP, BNP. That's all the heart can do, right? And what else? So the brain has neurons, but it doesn't actually. There's not. Because it has a lot of functions. Probably second place to the liver. The liver has a lot of things it does. It stores things, right? You have excess glucose. It's going to store it away as glycogen, right? Or it's going to get the hormones to store things away elsewhere, right? It stores vitamin B12 and stores copper and iron that we might need for certain body processes. It's going to degrade things. It's going to break down things. All right, breaks down, we mentioned bilirubin before, we talked about gallbladder stuff, breaks down drugs via the cytochrome P450 system. It's going to be working on, neutralizing things, right? That's why everything goes through the liver, through the portal circulation first, so we can detoxify whatever we might be intaking from our diet. And then it's going to be metabolizing things. It does anabolism and catabolism. Anabolism is the anabolism is breaking down, right? Catabolism is the building up of stuff, so we can build up and we can form new stuff, right? We can from glucose from new stuff. That's gluconeogenesis, right? We can start making ketones. We can start making all kinds of glucose sources for our body, right? We can start breaking the glycogen we just stored from before, and we can start breaking down lipids. We can start forming cholesterol. We can do all these things to synthesize things, right? I should say create things, because it synthesizes a lot of things. There's a lot of things it creates. One of the things is albumin, and that plays a key role when we talk about ascites and portal hypertension and such. And it synthesizes your coag factors, a lot of coag factors, except for von Willebrand. So von Willebrand, he's out in the dust in Transylvania. He's like, what about Sir von Willebrand? What about me, right? So he does not get made, unfortunately. But everything other coag factor does get made in the liver, therefore that risk for coagulopathies, right? Also, your risk for bruising and whatnot because of TPO, and we'll talk about TPO. That's thrombopoietin. It releases TPO to make your platelets grow, right? EPO was who? Who made EPO to make our erythrocytes grow? The kidneys, right? Not sure how the kidneys got that job, but the liver's like, hey, can you take one for the team, right? But yeah, TPO is our liver. All right, so we get coagulopathies and bleeding if we don't have that around, right? And there's other things that are made as well. A lot of hormones. It breaks down, what is it? It breaks down testosterone into, or estrogen, I think, and therefore, if you don't have, when you have liver failure, you don't break down estrogen, so you get hyperestrogenemia. You get gynecomastia, small testes if you're a man, and you get all kinds of other, like the spider nevi and other weird symptoms that might develop. All right, so it takes excess proteins, breaks them down, right, into amino acids, and the amino acids are going to form together, two aminos, right? NH2 is amino acid. It's going to form that with a little CO2, and that now is BUN, right? So that is what its goal is, right? So when you have excess protein intake, your BUN goes up, like in renal failure or like the GI bleeds. But in liver failure, this process is interrupted halfway through, right? So about right there. So you're trying to make BUN, but you get stopped. The factory is broken. It's cirrhotic and scarred, right, and burned to a crisp, and you can no longer send this through the assembly line, and therefore it stops at ammonia. So when you have excess protein breakdown, ammonia starts rising, right? So you can get hepatic encephalopathy, but that's only when our vessels are leaky, when we have a sepsis or SIRS process. So that's the primary reason why that would occur. All right, so the ammonia can build up. You get hepatic encephalopathy. You get coagulopathies because we're not producing TPO. We don't produce coag factors. And then bilirubin. Again, bilirubin we talked about with gallbladder stuff, but bilirubin is formed from RBC breakdown, right? So you're breaking down RBCs all the time. You produce a whole bunch of RBCs into circulation from your bone marrow, and you're breaking down a whole bunch of old ones, right? Senescent RBCs. And we are going to, neutralize them in the bloodstream with our by Valirudin and other fancy stuff, but those are called unconjugated bilirubin. And then it goes to our liver to get conjugated, right? So conjugated, unconjugated. If you add those two together, you have total bilirubin, right? And yes, you can have an elevation of this one, an elevation of that one, and this one can be low and that one can be high. And it can tell you if it's an RBC problem, like you're breaking down too many RBCs because you gave a blood transfusion that you didn't check the label of, and that's why their T-billy is high, is because the unconjugated billy is high because they broke down so many RBCs. Or they have like a sickle cell crisis, or they have some kind of weird reaction to some medications causing hemolysis of some sort, right? And then we have conjugated billy. So conjugated billy goes up when you have liver dysfunction, right? The liver itself is not working. Well, if the liver doesn't work, how is it conjugating, right? It's like halfway through the process, it's not finishing, right? It's not finishing the process. Therefore, we have hepatocellular damage to the liver cells. That's going to cause a rise in our conjugated billy. T-billy goes up. When T-billy goes up, what symptom do you get? You get icteric, of course. What the heck is icteric? Icteric is Greek for yellow, right? Like Icarus went to the sun, right? He climbed up the mountain to the sun, right? So then now he became jaundiced, right? So it's like, congratulations, you're cirrhosis, right? So that's not fun. Anyways, so you get icteric sclera. And that's because you're building up all this bilirubin, whether it be conjugated or unconjugated. Basically, the T-billy going up greater than 2, greater than 2.5, you're going to get icteric. You're going to get yellow and jaundice. And that's going to be very irritating to your skin, causing pruritus and itchiness, right? And all this excess bilirubin, this conjugated bilirubin, will make its way to the gut as well. Right, all this conjugated bilirubin will make it to the gut, and then your gut bacteria are going to convert that into urobilinogen, and that urobilinogen was going to get absorbed by your GI tract and then excreted in the kidneys, and you're going to have tea-colored urine, right? So dark Coca-Cola colored urine because of elevated billy and also elevated this urobilinogen. And you can actually do a little dipstick test, and you can assess if there's urobilinogen present, and it can tell you what's going on. It can tell you if I have a liver problem or not. Right? Because the last thing that happens when T-billy goes up is when my biliary tree is completely blocked. If my biliary tree is completely blocked with a cholestatic pattern, like an obstruction of some sort, like choledocholithiasis or biliary sclerosis, all these things that are preventing that bilirubin that is like half made, but it can't get to the GI tract at all, what's going to happen? Well, I'm not going to get urobilinogen, so that's why it's negative over here, right? My urobilinogen on my exam, and of course I'm not going to have dark colored urine anymore. But I'm also going to have stool that is not going to be brown, right? Because what makes stool brown is bile breakdown, right? So bile does get absorbed a little bit, but mostly bile stool is is made up of old bile. Okay, so you're going to have pale stools, pale clay-colored stools, right? When they look at their when they do an exam, right? So they might complain of this as well. So tea-colored urine, you can say, oh, you've got a liver problem. If they have clay-colored stool, you've got probably gallbladder situation happening, biliary tree problem. Okay, so that's the overview of what our liver does and some of the symptoms that might result from its inadequacies. Looking at more labs, obviously T-bili will be high, right? So T-bili starts going up when you have a liver inflammation of some sort. But what else goes up is your transaminases. Ases are enzymes, and trans means transport, and aminos means amino acids. So all it's doing is transferring amino acids from one place to the other, right? So there's aspartate, which is an amino acid, and there's alanine, which is an amino acid. That's 18. Now you have 18 other amino acids to memorize. But those are the two important ones that are found in the liver, right? So AST, ALT usually are 40 or less, right? And normal, and then they will start rising with liver dysfunction, right? Why would your liver be dysfunctional? So it could be because you consumed alcohol. It could be because you are on statins, or you were consumed too much Tylenol, right? So nicely, the mnemonic is AST is alcohol, statins, and Tylenol. That's what makes AST rise. Okay, so AST rises technically when you have mitochondrial dysfunction. AST is found in the mitochondria of the, right here, the mitochondria, they're in the nucleus, but to the side there, it was green. I think maybe green is AST. So, or it looks like it's gray there, but AST is found in the mitochondria of the cells. So mitochondria get dysfunctional, they're going to start breaking apart their insides, and then they are going to spill AST into the bloodstream, right? So what causes mitochondrial dysfunction are your statins will do it, alcohol is going to damage the mitochondria, and Tylenol will damage the mitochondria specifically, okay? So that will cause a spillage of AST into the blood, right? So those three things are going to rise. And then AST, though, is not only found in the mitochondria of the liver, it's also found in the brain, in the heart, more than any other place, actually. So when I have heart damage, right, like I have an MI, if you ran an AST, ALT on them, you're going to see the AST is higher than the ALT, right? The liver is kind of usually what we always think of first, but you can also think of muscle as well. Like when you have rhabdo, for instance, right, you're going to see a dramatic rise in the AST. Why? Because it's also found in muscles. Right, it's one of our diagnostic tests we do for to see if someone has rhabdo. We do a creatine kinase, CK, which is found in muscles. Looks like the troponin of muscles, right? And we also see a rise in the AST. All right, we also see a little hyperkalemia and hypercalcemia too. But kidney and pancreas are also involved. AST can be risen for many different reasons. Okay, and we start looking at ratios. So the ratio is AST to ALT, nothing else. All right, so AST ALT is how you should frame it in your brain. Unfortunately, it's not alphabetical. So it's AST to ALT ratio is going to tell you what is wrong. So the AST is greater than 1 in the ratio, right? So if it's 40 to 40, 40 divided by 40 is 1, right? So the AST goes to 80. 80 over 40 is 2, right? So that's the ratio is of AST ALT is high or greater than 1, right? And that's when does that happen? Alcohol disease, statins, Tylenol, right? Those are the top 3. There are other ones here, but that should make sense, right? Rhabdo makes sense because my AST is spilling, right? That's why my AST ALT ratio is greater than 1 in that situation. Okay, it rises with injury, but there are more mitochondria per cell versus ALT. Yes, the ALT, those statins are killing cells, but they're killing more mitochondria than cells, so that you're going to have more AST spillage overall. Okay, AST is always elevated in MIs, right? ALT will be normal in MIs unless the liver is damaged also, like severe failure maybe, and it's congesting the liver because it's not pumping forward maybe, but that's AST, right? What about ALT? So ALT, all right, also they have another street name from the 70s. Right, that's when they're in the street doing drugs. They're called SGOT and SGPT. You might have some older doctors that are going to might throw that at you. Like, well, what are you talking about? AST, ALT has been around since like the late 80s. Okay, so ALT. So ALT is found only in the liver. It's not found in the brain, not found in the muscle, not found in the bones, anywhere else, but is only found in the liver. So ALT rises when our hepatocytes start dying. Well, I thought AST also rises when hepatocytes die, but ALT is specifically made in the cytosol. So when the cytosol membrane starts getting broken down, right, that is when we're going to have a rise in our ALT more than AST. Okay, so the mitochondria are fine; they're not spilling their AST. So the mitochondria are fine. We're not having damage to the mitochondria; we're having damage to the cell itself. And when would the cell itself die? It's when we have a hepatitis of some sort, like hepatitis A or B or C or D or E or non-A, non-B, non-D, non-C. There's like 26 different hepatitises out there, right? You at school, you only learn A, B, and C because it's ridiculous after a while. B is absolutely ridiculous, but there's when you have a viral infection, a viral hepatitis, right? L, right, is alone in the liver, really stretching here, but you got ALT viral, right? L is due to or ALT rise is due to a rise in the L's or rise in liver damage from a viral infection, right? So ALT stays elevated longer, yes, but also it happens with hepatocyte death. ALT is only found with hepatocytes, not elsewhere, but also we have a viral infection. That's when you're going to have a rise in ALT more than AST. Remember, the ratio is AST to ALT, right? So the bottom number, AST divided by ALT, the bottom number gets bigger and bigger and bigger, right? Instead of 40 over 40, it's 40 over 400, right? That's going to be a much, much smaller number, less than 1. Right, so that's how they're looking at that. So acute hepatitis is an example of where my ALT is greater than my AST, or the ratio is less than 1. Okay, so AST to ALT less than 1. I got a viral cell membrane that got hijacked by Hep C or Hep B, even Hep A. These are all attacking the membrane itself. Okay, so that's the idea with our AST, ALT, and what the differences would be. We're still going to use bili. That's going to tell us, if AST, ALT is elevated, it could be a biliary problem, like ascending cholangitis, for instance, right? GGT was only for bili stuff, right? But here we're over here at AST, ALT. What's ALP? Alk-Phos in green. That was key for our bilirubin, right? That's what kind of sealed the deal, was our GGT, bilirubin, and alkaline phosphatase. When we talk about liver stuff, we know that stuff can damage the liver too, but we can look at the ratio between AST and ALT to give us information about what could be going on with the patient. All right, so acute liver failure. So acute liver failure happens when we have end-stage liver disease, symptoms acutely. So what is acute as far as liver is concerned? It's when you have damage to it within 26 weeks. So you have liver symptoms within 26 weeks of insult to your liver. There is such thing as hyperacute. That's called fulminant liver failure. That's like an acute decompensation. Someone overdosed on Tylenol, someone had a binge drinking episode, and now they have all the symptoms of liver failure immediately, right? They have hepatic encephalopathy, their ammonia is elevated, and they're comatose, right? And ulcer. They have a coagulopathy. They can't synthesize coag factors anymore, and they're bleeding and bruising everywhere, right? They're super, super jaundiced as well. Those are 3 key symptoms that can clue us in that they have liver dysfunction, right? If liver dysfunction happens within 7 days, it's hyperacute. If it happens in the course of 26 weeks, that is an acute liver failure, right? So acute liver failure is less than 26 weeks. All right, there's no other acute process that is 26 weeks long. That's stretching it. Okay, but if the liver failure happens after 26 weeks, then that's considered chronic liver failure. And we'll spend a lot of time with chronic liver failure, where they have acute decompensation, it keeps getting worse function over time, and we start getting complications of liver failure, like portal hypertension, and we get ascites, and we have more coagulopathies and more issues down the road. Hepatorenal syndrome, hydrothorax, cardiac cirrhosis, all these things that can develop from a cirrhotic liver. But right now we're on the front end over here. We're on a precipitant event, and one of those events could be, like I said, like a Tylenol overdose or a drug-induced liver injury. Someone gave amiodarone left and right, or someone gave statins left and right. Someone gave a medication that was an a-hole to their liver, like azoles, right? So fluconazole, for instance, is very, very hepatotoxic and cardiac toxic for that matter. Okay, there's no cirrhosis on these patients, but they have all the symptoms of liver failure, right? So drugs, 80% of the time it's drugs, especially Tylenol overdose, but it could also be drugs they were taking over time that were prescribed. I think it's usually like within a couple weeks or so of starting a new drug. That's what kind of clues you in, and probably is acute liver failure from that new drug, right? And then so that's the most common, 80%, and then we do 5% each for like viral problems. Hepatitis A develops acute hepatitis. and cause acute liver failure. And 70% of the time you just recover. But 30% of the time you have this liver damage and you can actually die from hepatitis A. It's a usually very recoverable disease, but you can develop acute hepatitis, acute liver failure within 26 weeks of your strawberries or salsa or romaine lettuce that you got from Trader Joe's, right? That could cause a hepatitis A, or like the most recent one was a Panda Express, right, over in Lancaster, where they had a hepatitis A outbreak, and it only happens with not washing your hands. It's only fecal oral, and there's no other reason for it. So some of them wash their hands, all right? So yeah, there's viral reasons. There's other reasons that you could develop a hepatitis acutely. Okay, so what else? So requires supportive care, and they might get through it, but if they start decompensating, then we need to consider them for a liver transplant. Okay, so there's all kinds of scoring systems out there. There's MADRS, there's MELD scores. There's 3 MELD scores actually. There's MELD sodium, there's MELD, and there's MELD plus. So it's like, I don't subscribe to any more streaming services. What the heck? And then there's King's College, which is specifically for Tylenol overdoses. They use this King's College. And you look at all these, the only reason I bring them up is because they explain the liver and the liver labs and the liver tests you're going to do, right? So you're going to see the INR is high. You're going to see the T-bili is high, which makes sense. You're going to see the ammonia is not really used on many of these, but sodium starts getting low with liver transplants. It's the model for end-stage liver disease. So towards the end there, you get hyponatremic. So it can tell you how bad your liver failure is based on how low your sodium is. It's factored in, the MELD sodium score specifically, probably the MELD plus too. All right, and then we have like alcoholic hepatitis. When someone overdoses on alcohol, they can do like a Lilly score. So there's all kinds of scores which we'll touch on when we talk about each one of these different pieces. Okay, so what else? So acute on chronic liver failure, that's when you have already established liver disease, and you now develop all these reasons to come to the hospital. So you develop spontaneous bacterial peritonitis, you develop routine paracenteses, you have a esophageal variceal bleed. So all these things are leading you to be hospitalized multiple times, and again, that leads to a reduction in liver function. Okay, and we'll talk about each one of these. We talk about like Tylenol overdoses. You give N-acetylcysteine or NAC or Mucomyst, which smells great. All right, and encephalopathy, no, it smells horrible. So then you got encephalopathies that will develop. That's one of the kind of the key markers that tells you how bad someone's liver failure is, right? So they can look at, there's different stages of hepatic encephalopathies. Like stage 4 is usually grade 3, grade 4 is where they start getting comatose at that point. Okay, so we'll talk about all these things, and we'll recap these things at the end of liver as well. And then we talk about hepatitis coming up. Those guys are going to have all kinds of tests you're going to do to see if they have hepatitis A virus on board, if they have a hepatitis B surface antigen or core antigen or envelope antigen, all the weird, and antibodies against those ones. It's a whole deal. Okay, so that's the idea behind acute liver failure. It's just all the symptoms of liver disease, right, that have occurred within 26 weeks.